Imagine arriving at your clinic ready for a day of patient care. You see a referral for jumper's knee and immediately think of patellar tendinopathy. But as you begin your assessment, the patient describes pain in the quadriceps tendon, not the patellar tendon. This scenario highlights a common misconception. Jumper's knee is not synonymous with patellar tendinopathy. It actually includes both patellar and quadriceps tendinopathies. While patellar tendinopathy has been extensively researched, quadriceps tendinopathy remains largely overlooked. This video will explore why distinguishing between these two conditions is crucial for effective treatment and patient outcomes. Jumper's knee is a term often used to describe pain in the knee's extensor mechanism, but it encompasses both patellar and quadriceps tendinopathies. Many clinicians mistakenly treat quadriceps tendinopathy with protocols designed for patellar tendinopathy, assuming the conditions are identical. However, the patellar and quadriceps tendons have distinct anatomical structures and functional roles. This difference means their risk factors, causes, and responses to treatment can vary significantly. Recognizing these distinctions is the first step toward designing more targeted and effective rehabilitation programs for each condition. Patellar tendon attaches bone to bone, connecting structures of similar stiffness. In contrast, the quadriceps tendon attaches muscle to bone, linking structures with dramatically different stiffness. Tendons adjust their stiffness along their length to efficiently transmit force from muscle to bone. When landing from a jump, the quadricep muscle contracts eccentrically and the quadriceps tendon acts as a shock absorber. If the tendon is too stiff near the muscle, the risk of injury increases. The patellar tendon is stiffer than the quadriceps tendon, and their structural differences influence how force is transmitted and how injuries develop. Patellar tendon is a linear structure with parallel layers, while the quadriceps tendon is more complex, arising from 4 separate muscles and typically having 3 layers. The number of layers and muscle contributions can vary greatly. This complexity means the quadriceps tendon is subjected to non-uniform loads and shear forces, unlike the patellar tendon, which experiences more uniform force transmission. These structural and biomechanical differences may impact the development, symptoms, and treatment of quadriceps tendinopathy, yet they are rarely considered in clinical practice. Patellar tendinopathy typically presents as pain at the inferior pole of the patella and is common among jumping athletes, with up to 45% of elite athletes affected. Quadriceps tendinopathy, on the other hand, causes pain at the superior pole of the patella, especially during deep knee flexion. Its onset is often linked to acute incidents involving high eccentric quadriceps loading, but symptoms are usually preceded by excessive load over time. Though less studied, quadriceps tendinopathy affects up to 2% of athletic populations, and among athletes with extensor mechanism pain, 1 in 4 may experience pain at the superior pole. Both patellar and quadriceps tendinopathies are overuse injuries caused by tendon overload and inadequate recovery. The primary symptom is load-dependent pain, which increases with greater activity. Treatment focuses on activity modification and controlled tendon loading to reduce pain, promote tendon remodeling, and restore mechanical properties. However, these similarities do not mean the same strategies work for both conditions. Understanding the unique anatomy and biomechanics of the quadriceps tendon is essential for tailoring rehabilitation programs and achieving better outcomes. Quadriceps tendon experiences greater loads than the patellar tendon during deep knee flexion. This explains why quadriceps tendinopathy pain is most pronounced in activities involving deep knee flexion. Graduated loading programs should include exercises that load the quadriceps tendon in deep flexion, but caution is needed if bony abnormalities are present. Some areas of the tendon may be stress-shielded or compressed, making them more susceptible to injury. Modifications to loading strategies may be necessary based on patient response, avoiding excess compression and targeting the pathological region. Pain is a valuable guide in clinical decision-making for tendinopathy treatment. Mild to moderate pain is acceptable during loading exercises, and pain should not exceed 5 out of 10 on the numeric pain rating scale. Symptoms should return to baseline by the next morning and not increase week to week. Because the quadriceps tendon is complex, force transfer may occur without loading the pathological region. Provoking pain during exercises can help clinicians identify positions where force is transmitted through the affected area, ensuring targeted treatment. Changes in muscle activation and tendon mechanical properties are common in tendinopathy. In patellar tendinopathy, reduced voluntary quadriceps activation is observed. In quadriceps tendinopathy, altered activation of the foremuscles may underload or stress shield the pathological area. Neuromuscular or functional electrical stimulation can help restore muscle function and ensure adequate loading across the tendon. The goal is to restore tendon mechanical properties and improve performance, recognizing that healthy patellar and quadriceps tendons differ and may respond differently to injury. Distinguishing patellar and quadriceps tendinopathy is essential for effective clinical management. Recognizing their differences in anatomy, function, and response to injury allows clinicians to make better treatment decisions. Future research should focus on identifying the most commonly affected regions, developing quadriceps-specific outcome measures, and conducting clinical trials to test tailored treatment programs. By acknowledging quadriceps tendinopathy as a distinct diagnosis, patient outcomes can be improved and rehabilitation strategies can be more precise and effective.